Hello everybody. Today's topic is invasive mechanical ventilation. So invasive mechanical ventilation describes the control or assisted ventilation through endotracheal tube, tracheostomy or laryngeal mask or esophageal obturator airway. So mechanical ventilation is used when the patient's spontaneous breathing is insufficient to sustain life, when it is useful to take control of respiration because of impending failure of other system, or to support patient through the deep sedation or therapeutic paralysis. So we'll see what are the modes of mechanical ventilation. Now, what is the physiology of the positive pressure ventilation? Initial ventilator modes were designed to deliver breaths of air mixed with oxygen at fixed volume, that is tidal volume and frequency. These modes did not take into consideration the patient's effort, and consequently, they were often associated with significant ventilator dysynchrony, requiring high level of sedation and paralysis. Subsequently, the new ventilator modes were developed that had capacity to sense the patient's inspiratory effort, improving synchrony of breath onset and termination. Despite this progress, the general prevalence of the ventilator dysynchrony in mechanically ventilated patients is estimated at up to 25%, with higher values in specific populations like chronic obstructive pulmonary disease and children. Lately, complex ventilator modes have been developed seeking to improve patients' ventilator synchrony, respond more readily to changing condition, and to adjust setting without clinical intervention. To understand ventilator mode, it is essential to first describe the key component of individual breath and is characterized by how the breath is initiated, that is trigger, what governs the gas flow during the breath, that is target, and how the breath is terminated, that is cycle. Ventilator modes are created based on which breath types are delivered and whether spontaneous breaths are allowed. So defining characteristic of the breath time, in volume control, the trigger will be time, the target is flow, and the cycle will be based on the volume. In volume assist ventilator, the trigger will be effort, target will be flow, and cycle will be volume. In pressure control, the trigger will be time, target will be pressure, and the cycle will be decided by the time. And in pressure assist, the trigger will be effort, target will be pressure, and the time will decide the termination. And in pressure support, the effort will be the trigger, then the target will be pressure, and cycle will be depending on the flow rate. So defining the characteristic of the breath type. So regarding trigger, mechanical ventilation breaths are triggered into the four positive ways, that is time, pressure, flow, and neural sensing. So the time is the trigger for controlled breaths, meaning that the breath will be delivered after fixed time from the prior breath, defined by the set respiratory rate or frequency. In contrast, assisted breath rely on the ventilator to detect the patient effort. Most commonly, the effort is sensed through a fall in pressure at airway opening or by detecting a difference in bias flow, comparing the inspiratory and expiratory limb of the ventilatory circuit, that is flow triggering. In majority of the ventilated patient, the means of effort detection has no significant impact on the efficiency of triggering or work of breathing and is selected based on the physician preference. However, in some clinical scenarios, such as in the presence of air leak, for example, a bronchopleural fistula is present, the choice of trigger can be important, since relying on the flow can produce auto-triggering, a form of ventilator dyssynchrony. Neural sensing, in which integrated diaphragmatic electromyography signal is used to initiate the breath, improves the neuroventilatory coupling, especially in patients with severe airway obstruction and in children. So the next is target. Ventilator breaths are conventionally classified based on the targeted variable. Pressure targeted breath versus flow targeted breath. In pressure targeted breath, the clinician sets the ventilator, and it produces the controlled pressure throughout the inspiration. Generally, inspiratory pressure is constant, although it can vary during the proportional assessed breath and those based on the diaphragmatic EMG. In contrast, during flow targeted breath, the clinician sets and the ventilator deliver control inspiratory flow rate. Generally, it is constant throughout the breath, but can also decelerate or vary sinusoidally. Although clinicians tend to think of pressure and the flow targeted breath as differing fundamentally, in fact, they are tightly coupled through the equation of the motion for respiratory system. This equation relates the pressure at airway opening, volume above the functional residual capacity, compliance of respiratory system, inspiratory flow, respiratory system resistance, flow acceleration, inertance, and the pressure produced by the inspiratory muscle. And they are related according to the following equation. According to this physiological relationship, during pressure targeted breath, volume and the flow depends upon the airway opening pressure along with compliance, resistance, and this pressure produced by the inspiratory muscle. So similarly, during flow targeted breath, the pressure during the airway opening becomes the dependent variable. So these points are crucial for two reasons. The ventilatory impact of pressure and the flow targeted breath are linked by the mechanical properties of the respiratory system. In passive patient, these include only compliance and the resistance, and this equation forms the basis for delivering the clinically important information about the respiratory system from pressure and the flow waveform, as discussed further later. So these are the schematic representation of the pressure and the schematic representation of pressure flow and the volume curve. So for passively ventilated patient on the flow and the pressure targeted mode. So as we can see in the the first diagram, the flow remains constant and the volume rises linearly throughout the inspiration, and the pressure is determined by the respiratory system of the mechanical properties. So we'll have look on the diagram again. Here flow is constant and this volume is increasing linearly, and the pressure is determined by the respiratory system. Whereas in the B diagram, the pressure remains constant and it becomes the independent variable, while the flow and the volume is determined by the respiratory system. As we can see in this diagram, the above line is a representative of the pressure and it is a constant, and this flow and the volume is determined by the respiratory system. So some unusual ventilator modes allow the dual control breath in which both pressure and the flow can be targeted within the single breath. For example, volume assured pressure support breath begin as typical pressure support breath, but if the projected tidal volume falls below the target, then the breath will switch to the assist control and the flow targeted breath until the completion. There is no apparent advantage to such a dual control breath and the modes. Now the next variable is cycle. The cycle variable is the factor that terminates inspiration, and there are four possible cycle variables, that is time, flow, volume, and neural sensing. Pressure control breath are terminated by the time, often set between 0.5 to 1 second. At any given rate, the inspiratory time determines the expiratory time. So there are important consequences to the time chosen, especially for patients with airflow obstruction. Flow is the cycle variable for pressure support breath, which terminates when the flow falls to specific fraction of the initial inspiratory flow on some ventilator and below an absolute threshold of the flow. Since the opening pressure is constant during the pressure targeted breath, it tends to decelerate throughout the breath as the lung volume and the lung recoil pressure rise and efforts fall according to the equation of the motion. Often a value near 30% of the initial flow is chosen to signal the ventilator to switch off, because among the normal subject, this tend to coincide with the cessation of the inspiratory effort. The rate of fall of the flow depends upon the mechanical properties of the respiratory system. However, for patients with the severe airway obstruction, this can lead to very long inspiratory time and the pressure ventilator dysynchron. For these patients, synchrony can be improved by raising the cycle threshold to 50% or even higher. The third means to cycle from inspiration to expiration is rely on the delivered volume, typically of the flow targeted breath. When the flow is constant, this is analogous to using the time to cycle the breath, since V is multi V is equal to the time. Uh, since the volume depends upon the time. Finally, inspiration can be cycle off by using declining cycle from a declining signal from diaphragmatic hinge. Regardless of the target, all ventilators have an additional maximum pressure limit as safety feature to prevent the lung overpressurization. This pressure is set by the clinician, often 10 to 10 centimeter of water above peak pressure. Whenever this pressure exceeds, the ventilator set off an alarm and opens the expiratory valve to release the rest of breath to the atmosphere. Now we'll see what are the ventilatory modes. For each mode here, we describe the component of the breath and setting the clinician must choose and impact the patient effort. Like volume assist control ventilation. Volume assist control ventilation mode allows both volume control and the volume assist breath. So is the time or effort triggered, flow targeted, and the volume cycle. In this mode, the physician sets the tidal volume, inspiratory flow rate, and respiratory frequency. And the I ratio, inspiratory time and the expiratory time, are determined by the combination of inspiratory flow rate, tidal volume, and the frequency. At constant tidal volume, the higher inspiratory flow rate and the shorter the tidal volume and smaller I ratio. So this is the diagrammatic representation of the volume assist control ventilation. As in most flow targeted, the flow remains constant and volume is rises linearly throughout the inspiration, while the pressure is determined by the respiratory system mechanical properties. The figure represents the passively ventilated patient, and the tidal volume, inspiratory time, and the respiratory rate set by the clinician determines the inspiratory-expiratory ratio and the flow rate. If the patient triggers an extra breath, then the same tidal volume would be delivered at same flow rate at the inspiration time, but I ratio would change. For passively ventilated patient, the set tidal volume is delivered with each volume control breath at specified frequency. If actively breathing patient, extra breath can be triggered each at the same tidal volume and inspiratory flow rate as a volume control breath, and this will change the I ratio and expiratory time. When respiratory drive is high or when neural inspiratory time exceeds the ventilatory expiratory time, the patient may trigger second breath, which is superimposed on the initial breath. This phenomenon is called as double triggering and is especially common during lung protective ventilation of acute respiratory distress syndrome and the risk over distension of the lung or dynamic hyperinflation. Now the volume synchronized intermittent mandatory ventilation. Volume synchronized intermittent mandatory ventilation entails the volume control, volume assist, pressure support, and spontaneous breath. So is time or the effort triggered and the flow and the pressure triggered, time and flow cycle. In passive patient, it behaves same as a volume assist control ventilation. In actively breathing patient, if the triggering effort occurs close to the next scheduled mandatory breath, defined interval or synchronization window, the ventilator delivers the volume assist breath and reset the interval until the next time cycle breath. If triggering efforts occur before synchronization window, pressure support and spontaneous breath follows. This ventilator mode has been used traditionally as winning strategy, although its use is decreasing, perhaps because it appears to prolong ventilator liberation. Now, this is the schematic representation of volume synchronized intermittent mandatory ventilation. The different breath types delivered by the volume synchronized intermittent mandatory mode in an actively breathed patient are as follows. Like control breath followed by the two asynchronized spontaneous breath and the synchronized assist breath. Notice that the synchronized assist breath is composed of same flow and the volume as volume control breath, but the pressure are lower in accord with the according to the patient inspiratory effort. Here the unsynchronized breath are spontaneous breath, but this can be the pressure support. Now the next is pressure assist control ventilation. This mode consists of both pressure assist and the pressure control breath. That is time and the effort triggered, pressure targeted, and time cycle. The respiratory rate, the inspiratory pressure, and the inspiratory time are set by the clinician, while the inspiratory to expiratory ratio is determined indirectly based on the rate and the inspiratory time. With every breath, the pressure rises quickly to the inspiratory pressure, although rise time can be set to slow and the rate of rise. Most of the rise time is zero during invasive ventilation, although a brief rise time can aid synchrony in some patients. For a passive patient without airway obstruction and with sufficiently long inspiratory time, inspiratory pressure and the alveolar pressure equilibrate at end expiration and tidal volume is predictable. The tidal volume is equal to respiratory compliance into inspiratory pressure minus P. Among pressure with the airflow obstruction or short inspiratory time, there will not be equilibration between the inspiratory pressure and the alveolar pressure, and the flow does not fall to zero at end expiration. And the tidal volume will be smaller than that of the predicted because it is based on the compliance and the inspiratory pressure. For a patient who is actively breathing, the tidal volume is often augmented by the effort and is usually larger than the predicted by compliance and the inspiratory pressure. In addition, active patients can trigger additional breath, increasing minute ventilation, reducing expiratory time, and increasing I ratio. Now the next is pressure assist control ventilation. Here the pressure is constant throughout the inspiration within the limits of ventilator to control it, and the inspiratory flow falls through the breath as the alveolar pressure rises. In this patient, the first breath is controlled while the next three breaths are assisted. The downward deflection of the pressure curve at the beginning of the inspiration represents the patient's inspiratory effort triggering the breath. Now the next mode is pressure support ventilation. Pressure support breath compromise this mode. The patient must trigger the ventilator to deliver the breath, so this mode cannot be applied to the passive patient. The clinician set the inspiratory pressure and the flow threshold for cycling the breath off, the rate and the minute. Ventilation depends upon the patient drive. For patient with the periodic breathing, the pressure support ventilation can amplify the hyperapneic periods and extend the duration of the apnea, especially when inspiratory pressure is set to high level. If this causes alarm to sound, reducing the level of the inspiratory pressure usually shorten and abolishes the apneas. Now this is the schematic representation of the pressure support. As a typical of the most pressure targeted mode, the inspiratory flow falls throughout the breath as alveolar pressure rises. And appreciate how tidal volume and inspiratory flow are determined in part by the patient's respiratory effort that can vary from breath to breath, while the opening pressure is maintained constant. Now the next is pressure synchronized intermittent mandatory ventilation. The combination of the pressure control, assisted pressure, pressure support, and spontaneous breath makes up the pressure of synchronized intermittent mandatory ventilation. The clinician sets a rate, inspiratory pressure, and the inspiratory time. This mode is therefore effort and the time triggered, pressure targeted, or both time cycle and the flow cycle. When patient is passive, then this pressure SMV simply becomes pressure control mode. When the patient triggers the breath in brief window before the planned time cycle pressure control breath, the breath becomes a pressure assisted breath. If the patient effort precedes this window, the pressure is instead pressure support or spontaneous. This assembly was created with the hope that it would ease the transition between the full ventilatory support and spontaneous breathing, but instead this invasive mechanical ventilation seemed to impede the weaning. Okay. Then this pressure synchronized intermittent mandatory ventilation. Similar to volume synchronized intermittent mandatory ventilation, several breath type can be delivered by this mode in an actively breathing patient. A controlled breath is followed by the two asynchronized spontaneous breath and synchronized assisted breath. Then the synchronized assisted breath can have same pressure profile as inspiratory time as pressure control. For unsynchronized breaths, the pressure support is set at 0 and the it will be set at 0. Now the pressure regulated volume control and the volume support ventilation. Although the name pressure regulated volume control suggests that it targets flow, in fact the pressure regulated volume control is the pressure targeted mode, allowing only pressure control and pressure assist breath. In this mode, clinician sets the initial pressure, inspiratory time, inspiratory pressure, inspiratory time, frequency, and tidal volume both. The ventilator automatically and continuously adjusts the inspiratory pressure to achieve the desired tidal volume. Therefore, if the pressure system, if respiratory system mechanical properties or the patient effort changes, so it will change the inspiratory pressure. This is one of the means of controlling tidal volume for patient with ARDS. Although compared with the volume assist control ventilation, it may increase the work of breathing. No patient-centered benefit have been described, and a similar mode is volume support ventilation, which uses pressure support breath also to achieve target tidal volume. Because it uses the pressure support rather than the pressure control and pressure assist breath, then the volume support ventilation differ from the PRVC in that inspiratory time and frequency are not controlled by the clinician. So this is the graph of pressure regulated volume control. In this passively ventilated patient, the clinician switched the target tidal volume from 800 to 500, appreciate how inspiratory pressure adjusted by the ventilator and decreases gradually to deliver the new target volume. The time axis has been compressed for illustration purpose. Now, airway pressure release ventilation. Now, this pressure controls, pressure support and spontaneous breath are combined in airway pressure release ventilation, making it time and effort triggered, pressure targeted, time and flow cycle. But this mode is characterized especially by the very long inspiratory time. In the absence of spontaneous respiratory effort, APRV is identical to PACV, that is a pressure assist control ventilation. The point of APRV, however, is to facilitate spontaneous breathing. This mode was created as more comfortable means for delivering inverse ratio ventilation and is often used in the severe ARDS to improve oxygenation. There are three downsides to the APRV. Tidal volume that exceeds the value throughout thought to be the lung protective, even when it is used with the protocol designed to target low volume ventilation. De-recruitment during this target low volume ventilation could produce the atelectasis trauma, and spontaneous breathing in early and severe ARDS may worsen the outcome. Clinical trials have shown no patient-centered advantage to this mode. Now the next is high frequency oscillatory ventilation. High frequency oscillatory ventilation, it is the alternative mode of the ventilation in which mean airway pressure is held constant while oscillating pump delivers the small tidal volume at rapid rate. So high frequency oscillatory ventilation has drawn interest in the management of the ARDS for two reasons. First, it could be lung protective by virtue of maintaining high airway pressure while superimposing only a very small tidal volume. Second, high airway pressure characteristic of a high frequency oscillatory volume has potential to recruit lung alveolar unit when PEEP is ineffective, thereby treating the refractory hypoxemia. The two large prospective randomized trial compared high flow oxygen oscillatory ventilator to conventional lung protective ventilation in circuit. The one of them was Oscar. That is, it involved 16,795 patients that were randomized to high flow oscillatory ventilation. Initial airway pressure was 5 above the mean airway pressure at enrollment, and the frequency was 10. To the conventional, it was compared to the conventional ventilation, and there was no difference in all-cause mortality 30 days after randomization or length of stay in ICU and hospital. So based on the trials, the high flow auxiliary ventilator should not be used routinely for adults. If high flow oxygenation ventilation is chosen as rescue therapy for adults with refractory hypoxemia, careful and serial assessment of fluid balance and right ventricular function is recommended. Then the next is volume assured pressure support. Rapid microprocessors allow the ventilator to respond to changing conditions so rapidly that the level of ventilatory support can be changed within the single breath. With volume assured pressure support, each breath begins as pressure support, but if ventilator calculates that target tidal volume will not be reached, it switches to the volume control breath. The clinician sets the inspiratory pressure and targeted tidal volume. Then the proportional modes of the ventilation. This mode is the form of pressure support ventilation where the inspiratory pressure varies throughout the inspiration as a function of the patient. Thus, it is the effort triggered, pressure targeted, and the flow cycle. Now, the proportion assist ventilation was created in response to the fundamental limitation of the conventional flow and the pressure targeted mode, and the ventilatory assistance is not proportional to the patient effort. In contrast, the proportional assist ventilation amplifies the patient's instantaneous effort throughout the inspiration, leaving the patient in control of tidal volume, inspiratory time, and the expiratory time. Now the next is NAVA, that is neurally adjusted ventilatory assist. This mode provides the pressure targeted breath in proportion to the electrical activity of the diaphragm, measured through microelectrode built into the nasogastric tube and placed at the level of diaphragmatic groove. NAVA is electrically triggered, pressure targeted, and the electrically cycled. The timing and the intensity of the ventilatory assist is determined by the timing and the intensity of diaphragmatic electrical activity. The end of inspiration and the opening of the expiratory valve is determined by this electrical activity of the diaphragm signaling reaching 40% to 70% of peak peak signaling. NAVA requires the correct positioning of the electrode sensor, normal diaphragmatic anatomy, and intact ventilatory drive and breathing reflexes. The ventilator also has safety mechanism. It switches to the pressure assist control ventilation or pressure support ventilation if electrical diaphragmatic activity is not detected. NAVA is thought to produce better neuroventilatory coupling than the other conventional mode, decreasing the prevalence of ventilator asynchron. Two clinical trials showed the increase in the ventilatory free days with NAVA in comparison to the conventional mode among difficult to wean patients and in those with the acute hypoxic respiratory failure and mild ARDS. So this is the waveform of NAVA. In this mode, the pressure targeted breath are delivered in proportion to electrical activity of the diaphragm. The lower part of the panel shows the timing and the intensity of diaphragmatic electrical activity, which determines the timing and intensity of the ventilatory assistance. Thank you.